series in November, and a very warm welcome to people who are joining us for the first time. I see a couple of you got your cameras on. Absolutely great. I wonder if I could just ask everyone, though, just to mute your microphones so that doesn't come over to other people. That would be really helpful. The session today is being recorded, so it will be available to you on demand after the session and for you to use in your practices for training purposes. Alongside that, I will also be sending a copy of the presentation and also a PDF of the presentation, again, so that you can either print out the PDF or that you can use the presentation, the PowerPoint presentation, for training purposes in your own practices. So my name is Pat Langley. It's an absolute pleasure to be back with you here today. Again, very big thanks to Greater Manchester Primary Care Provider Board for inviting me to do this series of webinars. It's an absolute pleasure and an absolute passion of mine to be able to try and take things that are a lot of people find a little bit complicated and a little bit difficult to get their heads around, and then trying to turn it into something that is simple, understandable, and something that you can put into practice in your own practices. And the aim of what we're going to be doing with this webinar series is partially to look at what the latest CQC mythbusters are, and there was a CQC dental mythbuster update to the safeguarding to Dental Mythbuster 29 back in September. So we're going to be doing safeguarding today. But there are lots of other mythbusters on the CQC website. So what is important, though, is that that we deliver what it is most helpful to you. So could I ask you, please, to feed back to Greater Manchester, to Rose and the team there, on any subjects that you would find particularly helpful, because at the end of the day, this is for you. To my knowledge, no other primary care provider board is doing this. So I think, again, we're very grateful to Greater Manchester for doing this, for all the practices that they work with. So without further ado, I'm going to start the presentation now. Though you may very well have questions, and I'm really happy to take questions. At the end, I'll stop sharing my screen and I will take questions. I do try always when I present to make things as upbeat and positive, and perhaps even introduce a little bit of humor in here and there, just to make the learning process easier. There is nothing upbeat, though, about safeguarding. So there will be no humor, there will be no updateness happening in today's presentation. It's a very difficult subject and a subject a lot of people really do struggle with. And we're going to do a little bit about the Mental Capacity Act as well, simply because CQC always asks about safeguarding, and they always ask about the Mental Capacity Act at the same time. So whilst then the two are not intricately linked, they are in the CQC's minds. So without further ado, here we go. So the aims and objectives are to ensure that you and all your team members understand the recently updated guidance on safeguarding and how to apply it and comply with it in your practice. The updated Mythbuster talks a lot about things like integrating safeguarding into your practice systems and processes, reducing the increased safeguarding risks where practice processes are weak, and ensure team members know what to do when a safeguarding situation arises. And so I think that that is what we're really going to focus on, those things, how to put those things into practice. And I'm also going to focus on the importance of your immediate response when a safeguarding situation occurs. Because at the end of the day, what we're trying to do is not just CPD for CPD's sake. We're trying to make sure that everyone feels prepared, and it is very difficult to feel prepared for what to do when you either get a disclosure or you notice something. We will also touch on the CPD requirements for safeguarding, because that is in the mythbuster. So why bother with all of this? You know, I've already mentioned CQC half a dozen times, if not more. So are we doing it because we're worried about the CQC inspection? Are we doing it because we want to make sure that all team members can answer the CQC's questions? You know what the questions will be. Or are we doing it because abuse and neglect are major problems and we need to know what to do? Well, overwhelmingly, the really important answer is because abuse and neglect are major problems, very common, and we need to know what to do when we suspect or are confronted with a safeguarding issue. So never mind what the regulators say, this is really to do with what would you do and how can you make sure your processes are as strong as they possibly can be. A theme running throughout this session will be that safeguarding is the responsibility of every member of the dental team. So it's not just a case of, oh, well, somebody else will take responsibility for this. Every single person in the practice has a responsibility for doing all they can in relation to safeguarding. So each person has their own part to play in recognizing and responding to the signs of harm and abuse in patients. It's not a responsibility, though, that we have solely on us, though, so we don't have to shoulder all the responsibility ourselves for safeguarding. And it is a shared responsibility between the social care services, integrated care systems, the local safeguarding authority boards, so that's the local safeguarding children board and the local safeguarding adults at risk board. Might also involve the police or British Transport Police, might involve schools, education, could involve community services, health services, so that could be GP services, hospitals, everything to do with health, probation teams, youth offenders teams. Yes, your practice and indeed all dental practices are part of this group that share the responsibility. And then organisations like the NSPCC and other organisations. So it is a shared responsibility. And this shared responsibility is called multi-agency working. And when it fails, the consequences are often catastrophic. And when I say catastrophic, it means somebody dies. And that happens with monotonous and terrifying regularity. And this seems to me that despite it being a legal requirement for these agencies, so these multi-agencies, of which our practices are one of them, one of the agencies, it is a legal requirement for everybody to join the dots and talk to each other, but still it goes on happening. You have situations like the terrible case of Sarah Sharif, who was murdered, and there was a call from social services to the house next door, wrongly got the address wrong the day before she was murdered. And this kind of thing goes on and on happening all the time. So I've been lecturing on safeguarding now for 15 years, and I'm not sure I've seen very much improvement. And it is really, what it is about taking all these pieces of the jigsaw, so each of those agencies that are listed there, it's about taking all of those and making sure they talk to each other so that you put the jigsaw together. So that's what it's all about. As I said at the beginning, the CQC has updated their Safeguarding Mythbuster, which is Mythbuster number 29. They did that in September 25. And it may not sound to you like there's a lot of difference, but there are some subtle differences in it. This is from their website. It says they've updated it to include safeguarding of adults, children, and young people. Well, my view is it always included that. So what are the things that are different? So they talk a lot about safeguarding being integrated into existing practice systems and processes. So linking this back to the multi-agency working, this is about making sure that you have robust systems in place for identifying and acting on safeguarding issues. And then CQC is also saying that very much that my theme as well, which is everyone who has contact with adults at risk, children and young people has a responsibility. And they also talk about statutory duties, including promoting health, safety and welfare of patients. Now, the commonest reason for a dental practice to refer a safeguarding issue is neglect. Dental neglect. And dental neglect is nearly always linked to other kinds of neglect as well. So that's what they mean about statutory duties, including promoting the health, safety and welfare of patients in our context in dental practice. And there is no doubt, as evidenced by the failures that continually happen in other parts of the multi-agencies, that the risks to patients are much higher where systems and processes are weak and team members don't know what to do when a safeguarding situation arises. I mean, that's not rocket science. You know, if you haven't thought about it, if you haven't practiced what you do, then how are you supposed to know when you're confronted with something, what the right action to take is? So CQC inspectors, when they visit to inspect you, will expect to see that you do have robust systems and processes for safeguarding, and that all team members can demonstrate their competence in safeguarding. Now, by that, I don't mean, and they don't mean, just having done the training. They will ask questions about how you ensure that your systems and processes are robust. They may ask you what you would do in different safeguarding situations. And every single team member needs to be able to answer their questions competently and feel confident that they can answer them. They'll expect to see that you give that you give sufficient priority to safeguarding. What do they mean by that? By that, they mean that it is something that never falls off your radar, so that you have regular practice meetings, or at your regular practice meetings, safeguarding features on the agenda on a regular basis. Doesn't have to be every month, but it should certainly be regularly. If you don't do that, then it falls off your radar. And when you are confronted with a situation, then if you haven't thought about it for some time, then it makes it much harder to do the right thing. They will expect to see that, and this is a quote from the Mythbuster, that you have active and appropriate engagement in local safeguarding procedures. That means that you understand and what the local procedures are, that you have a note of where the contact details for your adults at risk safeguarding board and your children safeguarding board, that you know what the contact number for the NSPCC is, that you know how to do what you need to do as and locally as and when a situation arises. They will want to see evidence that team members take a proactive approach. This is all the things I've already talked about. Focus on early identification and prevention. Now, from that perspective, I think putting that in a dental context, that second bullet, focus on early identification and prevention, going back to what I said about neglect being the commonest reason for a safeguarding referral in dental practices. then this is where early identification and prevention come into their own in terms of identifying dental neglect and how this can be prevented, and then take steps to protect patients from known risks. They will expect that team members know how to respond to the signs or allegations of abuse. And I'm going to talk a little bit more about that in more detail. I'm going to talk about what the signs are. They will expect that you know what information to record, how to record it, and also how to respond so that you are getting the right information to record, and work with other organizations to implement protection plans. That's the multi-agency working I was talking about. They will expect to see that all team members, this is all from the Mythbuster, by the way, all team members have the appropriate level of competence for their role, and different roles in the practice are required to do different levels of safeguarding training. I'll cover that in just a moment. So appropriate level of competence for their role, and this is new, including through face-to-face training. I think there's been a lot has happened in the past, which is always practices always doing online training. That, in their view, is not now enough, and I share that view as well. And then evidence that minimum role-specific training has been undertaken at regular intervals, including at induction training. They will expect to see that you have a designated safeguarding lead. So let's just focus on the safeguarding lead now and what their role is. Well, if we go back to my jigsaw analogy, I see the safeguarding lead's role as being the person that joins the jigsaw pieces in the practice, and then also looks at what you need to do when there is an issue, and in terms of referring out to the multi-agencies we've talked about. Just to be clear though, a safeguarding lead is not expected to be an expert in safeguarding. They are the person that puts the jigsaw pieces together. They should be responsible for overseeing everything that happens from a safeguarding perspective in the practice. They should be responsible for ensuring that all your policies and procedures are up to date, that everybody's read them, understood them, asked questions on them if they haven't understood them, signed to say that they've read and understood them, and that these policies and procedures are implemented, so that in effect your policies and procedures aren't just a paper waste of time, basically. So your policies and procedures must lay out what you would do in a situation where you recognize that there's a safeguarding issue. They will also expect the safeguarding lead to ensure that all team members are appropriately trained and supported, and that they continually stress this message that safeguarding is everybody's responsibility. So what characteristics and qualities should a safeguarding lead have? Well, they should be a good listener, somebody who can listen without interrupting. Towards the end of the safeguarding session, we're just going to do a small piece on body language, because body language in this context is extremely important. So listening actively, and they should be good at this. They should have respect for and know how to manage confidential information. They should be able to handle difficult or distressing issues sensitively without overreacting or underreacting or reacting inappropriately. And they should be somebody who thinks before taking action. Their duties are to make sure that your list of local contacts for safeguarding advice is up to date, referral information, and ensuring this is easily accessible to all team members. So one thing that is a really good idea is that you perhaps put on a tab on the desktop at reception desk, so an easy click-through tab that will take you through to the safeguarding boards and their contact details. And everybody should know that that is there. Duties include organising staff training. Now, whether that's within the practice, so something the safeguarding leads, whether you bring a trainer in, or whether it is online CPD, then it's the safeguarding leads to organise that and also to check that everybody has undertaken that. Training the team on your safeguarding policies and procedures. This is different from the safeguarding training that you do either online or face-to-face. So this is making sure everybody in the practice understands what your policies and procedures say. And then auditing the practice on safeguarding matters. You might say, well, what do they need to audit? Really just that things have happened as they should happen. Also, all of the things that we've already talked about, making sure that your policies and procedures are up to date, auditing your policies and procedures to make sure they are where they should be, making sure that the local contacts are all up to date. So those are the duties of a safeguarding lead. So it is really important you choose the right person for that very important role. So let's just look at what the safeguarding CPD training requirements are. So for non-clinical team members, so that would be receptionists and administrators. Now, given that practice managers are often the safeguarding lead, then that would not include them in safeguarding level 1. It should be a higher level of training for the safeguarding lead. Now, there is a lot of rumour mongering about, oh, well, the CQC expects to see level 3 for safeguarding leads. They don't. It is optional. So if a safeguarding lead chooses to have safeguarding level 3, that's fine. Safeguarding level 2 is also fine. Safeguarding level 2 is usually reserved for clinical team members, so dentists, hygienists, therapists, and dental care professionals. So, so that is level 1 and level 2, and then level 3 is for clinical team members like pediatric dentists and pediatric dental care professionals. So it is a myth that all safeguarding leads need level 3. They don't. If you choose to have level 3, then happy days, but it isn't a requirement. So what are the hours of verifiable CPD? Well, level 1 should be 2 hours of verifiable CPD. Level 2 should be 3 hours. Level 1 and 2 can also be carried out by online training. Should be at least every 3 years. My personal opinion here is that is nowhere near frequent enough. Although if you have regular practice meetings and you discuss it all the time, every 3 years, formal training probably is enough. And it should always be part of your practice induction program. So any new recruit to the practice should have safeguarding training. Now, I've mentioned this already, I know, but it has always been my view that practice teams should have face-to-face training in safeguarding, with online training being an adjunct to this. And it would now appear that this is also the CQC's view on this. And the reason I think that is that face-to-face training, preferably in the practice, not in a huge group. I've given lectures where there've been actually 1,000 people at the lecture, well, that's a few years ago now, but regularly, there'll be 100 people there. And face-to-face in the practice allows your team to explore all aspects of safeguarding in a safe environment. I mentioned at the start, just what a difficult subject it is, and you may unknowingly have people who find this just so challenging that they can't be in a big environment listening to this. But making the environment as safe as possible within the practice is a really important thing to do. It also allows the team to discuss together how you would handle safeguarding issues when they arise. This is going to be another thing that I will keep coming back to as to how important this is, so that when you are presented with a situation that you know is something that you should be concerned about, what do you actually do? I am aware of people are answering questions. If it's okay, I'll take the questions at the end. And thank you for asking questions. That's really, really helpful. How could you provide face-to-face training? Well, there's a couple of ways, really. Your safeguarding lead might be able to do it, but given what I said earlier, which they're not expected to be a safeguarding lead, they're not expected to be an expert in safeguarding. Probably a better option is to bring a trainer into practice. So you must ensure that all team members, this is from your training, you must ensure that all team members know how to recognize the signs of abuse, neglect, and harm, how to respond appropriately to a safeguarding disclosure. So that is where somebody tells you something or a safeguarding concern. Know the right place to refer and the right people to refer to, and know what you need to do to record events accurately. I'm going to cover all of those things, not in a huge amount of detail because there isn't time on a session of this length, but we will touch on all of those things. So these recognize, respond, refer, record, these are known as the 4 R's. And what the 4 R's is a systematic approach to safeguarding. So the first of the R's is recognizing. That involves somebody disclosing something to you. Now that could be a disclosure statement, or it could be you noticing something in terms of behavior. But whatever it is you coming to the conclusion that you are recognizing something that is either abuse or neglect, or could be. The second R is responding. So that is how you respond immediately. And when I say you, I mean each one of you individually and personally. How do you respond when confronted with a situation? The third R is referring. That's another one that requires disclosure. So that is you then disclosing the issues and concerns to whoever the appropriate person is to disclose them to. That is when you refer, and making sure that you refer to the right place. And not only that, that you follow up after a referral just to make sure that the right things has happened. And then the fourth R is recording. Bear in mind that the records that you make could end up being crucial to the outcome of a court case. So recording, all of those things are of equal importance. So there's a difference between referring and then notifying. So all practices must refer all safeguarding concerns appropriately. And in some situations, you are also required to make a statutory notification to the CQC. You don't need to notify the CQC about all referrals. So you may, and we're going to come on and look at some examples in just a minute. So not all referrals need to be notified to the CQC. When you do need to notify to the CQC though, and this is a statutory requirement, it's mandatory, you do need to notify the CQC if the allegation of abuse relates to the provision of dental care in your dental practice. So let's look at some safeguarding scenarios, and these are all from the Dental Mythbuster. So we've got a mother visiting with a 7-year-old patient A who appears unkempt and is very dirty. During the examination, the clinician identifies bruising on the child's face and neck. Clinician asks the mother about the bruising, but her response does not explain the cause. Clinician refers to the local authority safeguarding children's team. In that situation, upsetting as it is a statutory notification to the CQC required? Answer, no, it is not. The abuse is not alleged to have occurred, so that's the bruising on the face and neck, is not alleged to have occurred while the child was at the practice, and it did not happen as a result of dental care or treatment. So that's the notification side. The referral side, though, is that clinician that recognizes that abuse, potential abuse, must follow all the practices safeguarding processes. So that's recognizing, responding, referring, and recording. So we need to separate out notifying the CQC from referral. Some situations need notification and referral, some only need referral. There's never a situation in which you would notify the CQC and not refer according to your local safeguarding procedures. Let's look at another scenario now. So patient P visits the practice with his 14-year-old daughter, patient Q. Patient P is very upset and tells the dentist that the practice manager has been contacting patient Q, 14-year-old daughter, by telephone and tried to arrange to meet her. Practice manager has also written patient Q some notes. So is statutory notification to the CQC required? Yes, it is. So the alleged abuse involves a practice employee, meaning it's related to the dentist's regulated activity. So it happened during the course of a regulated activity, which is what we all provide to our patients in practice. And in addition to that, the dentist should follow the practice safeguarding processes. So in this case, it's a notification and a referral. Let's look at another scenario now. Ms. L visits for a routine checkup. The dentist notices bruising on her cheek. She says that her partner has hit her. Is statutory notification to the CQC required? No, it isn't. It isn't alleged that the abuse relates to the dentist carrying on their regulated activity, but just like with the first case, you must follow the practice's normal processes for safeguarding adults and domestic abuse. So this is a case where no notification to the CQC is required. Yes, referral is required. And then the very last one, patient G, and this relates to something we're going to look at later in the presentation as well. An older patient with dementia attends the practice, needs an injection. This is very common. Everyone will identify with this. On seeing the needle, she becomes highly agitated. The nurse attempts to calm the patient. When that fails, the nurse then forcibly restrains the patient to allow the injection. Patient G's arm is bruised, her son makes a formal complaint to the practice manager. Is statutory notification to the CQC required? Yes, it is. The nurse allegedly committed abuse during the carrying on of a regulated activity. You should notify the CQC as soon as possible, even if it's only alleged and not proven. And in addition, the safeguarding lead should discuss with the nurse and the practice team. Now, this brings in the subject of restraint, which I will cover towards right at the end, actually, of the safeguarding section before we move on to the Mental Capacity Act. So what does the GDC say about it? Very similar. I'm not going to read all of everything out because I've got a couple of slides on this, but the thing I want you to notice though is that it says must. So you must, this is direct quote from Standards for the Dental Team, you must take appropriate action if you've got concerns about possible abuse of children or vulnerable adults. You can tell it was written quite a long time ago because vulnerable adults are now called adults at risk. And you must raise any concerns you may have about the possible abuse or neglect of children or vulnerable adults. That's a direct quote from Standards for the Dental Team. Now, here's the really important thing, because that there are a huge number of barriers to referring and disclosing. But if you, as a GDC professional, registered GDC registrant, make a decision not to refer and not to share your concern appropriately, you must be able to justify how you came to that decision. So I would always say that, not just because this is what the GDC says, but for all the other reasons, if you have any reasonable doubt, then you must act appropriately and refer to the appropriate authority. They also say all the same things as the CQC, so you must know who to contact for further advice, how to refer to local social services or whoever, it happens to be the police or whoever. And you must also find out about and understand the local procedures in place in your area and follow them if you are suspicious. So I've talked a lot about the regulators there. So should we just be concerned about safeguarding because of what the regulators require? Well, I'm not sure how much louder I can shout on a slide. No, 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 and double, treble, quadruple no. That is not the reason we should be concerned about safeguarding. It is not because we are fearful of the CQC or the GDC. All abuse and neglect is underreported. That's a fact. So that means that we have absolutely no idea about the true scale of the problem. Now, during and since the pandemic, all aspects of abuse and neglect have got a whole lot worse, and particularly domestic abuse. And when you throw in the cost of living crisis as well, neglect becomes really something that again is almost endemic in our society. So it is incumbent upon us to do all we can to help. Let's look now at recognizing, responding, referring, and recording, and just look at an example here, or a couple of examples. So I've said a couple of times, your initial response is crucial. So how you respond when you're confronted with an alleged or actual safeguarding issue is of paramount importance. So, and again, I'm going to keep coming back to this. It's essential that you discuss and agree on how to respond as a team. If you just are sort of working on your own, listening to this presentation, and actually you don't talk about it as a team, then you will not know what to do and you won't be prepared. And so you must practice how you would respond in different scenarios with your practice team. And if you don't do that, you won't be prepared. So how should you respond if you suspect abuse? First of all, we just need to understand what your role is in this. So your role is not to find out chapter and verse about everything, not to interrogate, not to go into minute detail about everything. Your role is simply to find out whether a referral is necessary. Now, quite often, a patient who is talking about potential abuse or neglect or domestic abuse, they will be upset, they will be agitated, and they may not necessarily be making a huge amount of sense. So if you're not clear about what they're saying, then ask for clarification. And to do that, you need to make sure that you use open questions. I'll describe a bit more about that in a minute. Essential that you remain calm and reassuring. Essential that you say the right things. Essential that you never ask leading questions. And I'll cover what leading questions are in a moment as well. The reason you mustn't ask leading questions is that if you do, that could contaminate any evidence and it could go against the victim in a court case. Don't make promises you can't keep. So let's imagine a situation where a young child, perhaps we're in November or December, and they say to you, "Can I tell you a secret?" And you're thinking in your head, "Oh, they're probably going to tell me where they found their Christmas presents, where they're hidden." You can't make that assumption. So if you then answer to the child that says, "Can I tell you a secret?" Yes, 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 go on, tell me a secret. And they then disclose to you that they are being abused, then you have made a promise that you can't keep. And if you make a promise you can't keep, that child or abused person won't trust you. And you may find that abused people give clues over a period of time, and they might be testing you to see if they can trust you. So the right answer to "Can I tell you a secret?" is, it depends what the secret is, and I might not be able to keep it secret. So, if they're bursting to tell you where their Christmas presents are hidden, then they'll probably still go ahead and do it. But I think it's very important that you never make promises you can't keep. And again, coming back to practice what you would say in a team meeting. Let's look at this, which I don't think anybody could be in any doubt about whether this is or isn't abuse. That's a hand slap mark on this child's face. So how would you ask open questions, and what questions shouldn't you ask? Well, the first question to ask is an open question, which is, what happened to you? Or how did you do it? Open questions start with what, when, how, who, why. So let's say the little girl responds with, "I fell over." Well, clearly that may be true, but this injury has not resulted as a result of falling over. When did it happen? She responds with, "I can't remember." Starting to think a little bit suspicious now. That's a significant injury. Not to be able to remember that when that happened, unlikely really. Can you tell me a little bit more? That is an open question, even though it doesn't start with who, when, why, how, where. What? Little girl responds, "I fell off my bike." So this is quite common in a safeguarding situation like this, an abuse situation like this, is the person changes their story, and the story doesn't fit with what you can see in front of me. So, the first line of questioning, "I fell over," hasn't stopped you asking questions. So now the little girl has come up with a different answer. So I think we can, apart from the visual evidence, which is very clear that this little girl has been slapped, then I think we can be very sure that we are recognizing this as abuse. And then responding correctly, make sure you answer open questions. Don't ask leading questions. Don't say, "Did so-and-so hit you?" That's a leading question. So just ask open questions so that you can have enough information to decide whether you're going to refer. Clearly, in this case, it does require a referral. And then after you've referred, it's really important that you follow up on the referral to make sure that the right things have happened. Social services are hugely overwhelmed, hugely understaffed, and just really not in a good place at all. So you do need to follow up. This might even be a case that you refer to the police. And then you need to record everything, bearing in mind, as I said earlier, that your records could be crucial in the case as and when a case comes to court. So I said I would focus a little bit on communication skills. And the reason I want to do this is because using appropriate body language, appropriate tone, and appropriate words are really, really important in terms of recognizing and responding. So learn to read and interpret other people's body language. I don't think you need to be a body language expert to interpret that what these two little girls are thinking. Body language is hugely, hugely powerful. And body language makes up anywhere between about 55% and 60% of all messages. So learn to read and interpret other people's body language. Equally, though, be aware of the non-verbal messages your own body language is giving. I don't know whether there are any fans of the Traitors on here, but if you watch them at the round table, and apologies to those who have never watched the Traitors, but if you watch them at the round table and indeed at breakfast the next morning, their body language gives pretty much everything away, apart from the very successful Traitors who are very good at doing that. So the point of raising that is really just to stress how very important body language is. So be very aware of the non-verbal messages your own body language is giving. So think about the child that says to you, a parent or carer or somebody is beating me. You know, if you react like that, you know, sort of sit back in horror, then that is going to discourage the child from disclosing any further. So it is really important and really powerful. Tone of voice. Tone of voice makes up about 30 or so percent of the message. So listen carefully to the tone of the voice the person disclosing to you is using, and be aware of any changes. So be aware of if the person disclosing to you suddenly becomes more guarded and uses a sort of uncertain tone of voice. Equally, be aware of and careful with your own tone of voice so that it stays level and calm and reassuring. Now, it's often said actually that body language and tone of voice are all you need. That, of course, as we all know, is not true. But it is a relatively small part of the message. So choose your own words carefully. Don't ask the wrong questions. Don't ask leading questions. Choose your own words carefully. Listen carefully to what is said and also to what is not said. And what is not said can often be as important as what is said. If you are unclear about what is said, don't make assumptions about what you think you heard or what you think the person meant. Ask for clarification using your open questions. So we're going to look now at some safeguarding do's and don'ts. So the do's are all in green and the don'ts are all in red. So we've talked about all of these things already. So we're just going to summarize really here. So do appoint a safeguarding lead. Do make sure that the safeguarding lead understands their duties and also has the characteristics that we talked about, being calm and reassuring, and a good listener as well. Do make sure that all your contact details for local boards, and they do change when I update our compliance policies on safeguarding. I am amazed at how often local safeguarding boards change their phone number or their email address or their web contact details. So do make sure that all contacts are kept up to date, readily available. I've already suggested that you perhaps have a tab on your desktop monitor. Ensure all your policies are up to date, in date, with a review signed and understood by everybody. Do know the confidential NSPCC Child Protection Helpline number. It's there. you can get little cards from the NSPCC just to stick behind reception so that you know that it's there, or you could just print it off and put a copy, laminate it and put a copy there yourself. But it is a really, really useful helpline to have quickly available to you. It is confidential, and it is a place that people with concerns about child safeguarding often turn to first. They are very, very good. So make sure you know the confidential NSPCC Child Protection Helpline number, and do follow up all referrals to make sure action has been taken. So follow up all referrals wherever you've referred them to. So that could be to the police, to social services, to a doctor, wherever, whichever one of the multi-agencies you refer to, or maybe you've referred to more than one, just make sure that action has been taken. Do include safeguarding regularly on your practice agenda. If you don't, it'll slip on everyone's radar. What do I mean regularly? If you have a practice meeting every month, then maybe every couple of months, every quarter. Probably don't leave it as long as every 6 months, because 6 months is a long time. Do record missed appointments for children and also adults at risk as what was not brought. So this, I'm sure you'll all be aware of. Was not brought has now replaced certainly what I used to use, which was did not attend or patient failed appointment. By recording was not brought, you are placing the focus on the person whose responsibility it was to get patient there, if it's an adult at risk or a child. Do also be aware of something called disguised compliance. So this is particularly important when you look at dental neglect. So imagine the scenario: you've got a parent or a guardian brings a child in, you see rampant caries, very poor oral hygiene, you give advice, and the parent or guardian seems to be following your line of thinking and your advice and your guidance, and they say, yes, I'm going to do that. And then when they come back, if they come back, it's very clear that they haven't followed your advice at all. That's what is called disguised compliance. So they say they're going to do it and then don't. So do make sure all team members have been trained at the appropriate level. We looked at that at the start. If you want a refresher on that, then as I said, you'll get the presentation afterwards, and do ensure that it's included as part of all induction training. Some don'ts now. And these are important ones. So don't let fear stand in the way of you doing the right thing. It is very daunting, and there will be lots of thoughts going through your head. Let's say you see the little girl with the slap mark on her face, then I think there will be all kinds of thoughts that automatically go through your head. You know, what if I'm wrong? What if it was not what it looks like? And this is normal, and it's a natural human response. It is important, though, that you don't let that stand in the way of doing the right thing. And also never assume that someone else will pass on vital information. So don't think, oh, well, I know so-and-so saw that as well, so they'll do something about it. Safeguarding is everybody's individual responsibility. And also don't leave the decision to share information to see what happens. Do it in a timely manner, and make sure that it gets put into the system in a timely fashion so that the right things hopefully can happen. Now, there's often a lot of questions around when you do and don't need consent to share information. We're all very aware of all the requirements of GDPR and data protection. So I want to be really clear on this. If you think that the alleged victim is at risk of harm by you sharing information, seeking their consent or anyone's consent to share, then you don't need consent. Now, it is true that all the advice and guidance says seek consent to refer. It really depends what it is you're seeking consent for. Imagine the situation where the child has said to you, such and such a person beats me, and this is not as rare as one might think. Imagine that situation where you then say, ask the person who is alleged to have beaten the child or adult at risk for their consent to share information, then I'd be pretty certain that you are putting the alleged victim at risk of further harm. So just to stress, you don't need consent to share information if you think that sharing will put the alleged victim at risk of further harm. And don't panic if you receive a disclosure or notice potential or actual abuse or neglect. Just stay calm. We've talked about this already. Again, it's not that easy to do. Somebody says something or you notice something horrifying and you think, oh, I can't really believe what I'm seeing. Just don't panic. Just remain calm, remain reassuring. Do follow safe recruitment processes. There have been well-publicized cases of heinous monsters who safe recruitment processes have not been followed, and DBS checks have not taken place, and people have slipped through the net and been able to abuse. One of the things that it's a really good idea to do is when you are recruiting for new team members, then include your child protection policy for potential job applicants. That has been proven to put off potential abusers. And do take up references before confirming employment. So those are safer recruitment processes. So that's it for the safeguarding section. What we're going to look at now is the Mental Capacity Act. And the aim of that is to help you understand your obligations under the Mental Capacity Act, but also a little bit about the regulators' expectations. We're going to cover the 5 key principles of the Mental Capacity Act and how they apply in dental practice. And then we're going to look at restraint. So if you remember one of the notifiable events, it was a restraint situation. So we're going to look at restraint as part of this part of the presentation. So let's look first at what the Mental Capacity Act is. Well, it provides guidance on how to ensure the best decisions are made about the care of patients who don't have capacity to make some decisions for themselves. It always starts with the assumption that patients will continue to make decisions as far as possible. So what the process involves when treating anybody, but I'm going to apply this in a dental context, is that patients can make some decisions themselves, absolutely. Can they make all the decisions they need to in terms of the care that, in your view, they require? And then if it's not possible for them to make a decision, then it is important that decisions are made in patients' best interests. So we're going to explore that and what it all means. So the Mental Capacity Act has 5 key principles, and it has to start with the fact that a person must be assumed to have capacity unless it is established that they don't. So you don't start from the perspective of, well, I don't think they're going to understand this. I don't think they've got capacity. I don't think they're going to know what I'm talking about. You must start from the perspective of that you assume that the patient does have capacity unless it's established that they don't. The next thing after that is that a person must not be treated as unable to make a decision unless all practical steps have been looked at to try and help him or her, and you've been unsuccessful on that. I'm going to talk about that a bit more in a minute. That's key principle 2. Key principle 3, which always makes me smile slightly, actually. I probably know it shouldn't, but it does. So you shouldn't and mustn't treat a person as unable to make a decision just because they've made a bad decision, an unwise decision, a risky decision, much like this gentleman who is shortly going to fall flat on his back when he gets through sawing the branch of the tree off. So that the point of this really is just to say that just because somebody's made a decision that you think is crazy, provided they understand everything you've said and are competent to understand it, then you can't say that it's a Mental Capacity Act issue just because they've made an unwise decision. Principle number 4 is an act done or decision made under the MCA for on behalf of a person who does lack capacity must always be done in his or her best interests. I think that's very logical, goes without saying. And then the last one, which is not really as applicable to us in dental practice, but decisions must be as least restrictive of freedom as possible. So obviously talking about restricting freedom is really talking about hospitals and care homes. It does apply in part though in dental practice. So ask yourself if there are alternatives to relying on others to help with decisions. And I'll talk about what I mean about that in just a moment. So we're just going to look like we did with safeguarding at the role of the regulators. And just so we're clear, the CQC has no powers to enforce the Mental Capacity Act, but under the Health and Social Care Act regulations, which are what guide the CQC in everything they do, and it's those regulations that we have to comply with in dental practices and in fact in all parts of health and social care. So the health and social care regulations have very similar requirements around involvement, choice, decision-making, and treatment planning. So just to be clear, CQC can't enforce it. They will expect you to be doing the right things though. And as I mentioned at the beginning, the reason we're including this here is that CQC inspectors routinely ask dental practice members about the Mental Capacity Act, and they will expect all team members they speak to, and bear in mind they might speak to everybody, or they might just speak to random team members. They will expect everyone to have detailed knowledge about how it applies in dental practice. And I have to say that in my own practice's CQC inspection a couple of years ago now, one of the hygienists from our practice had not been on a course on the Mental Capacity Act, knew absolutely nothing about it, and that really wasn't a good thing. And that then means the CQC is going to ask you all kinds of other difficult questions. Now, just like it's not all about the regulators, which it isn't, it is also partly about the regulators. So, role of the other regulator that affects us, the GDC. So GDC standards for the dental team acknowledges this is a really complex issue. And to quote standard 3.2.4 from the little scary grey book, you must always consider whether patients are able to make decisions about their care themselves and avoid making assumptions about a patient's ability to give consent. So what are some of the factors that affect capacity? Well, some of them are long-term, some of them are permanent, some are short-term, and some are intermittent. So the sorts of things that we're talking about here are stroke, brain injury, mental health conditions, dementia, Alzheimer's, a learning disability, confusion or drowsiness caused by illness or treatment, substance misuse, and anesthetic or sedation. So all of those things can affect the Mental Capacity Act of somebody to make decisions about their care. The Mental Capacity Act has a two-stage test of capacity. And this is for you to ask yourself, is there an impairment of or disturbance in the functioning of the patient's mind? So if you go back to this, so Has the patient had stroke, brain injury, or any of these things that is affecting the functioning of a patient's mind? If the answer to that is yes, then is that impairment or disturbance sufficient that they lack capacity to make a particular decision? So can you see that how they're constantly referring back to making it as least restrictive as possible within the Act? So let's look at how you would try and assess this. So a person lacks capacity if they can't understand what you're saying to them, can't understand the information you're giving to them that is relevant to the decision about their treatment. They can't remember it, so they can understand it when you're telling them, but they can't remember it long enough to make the decision. Or they can't weigh up information relevant to the decision. So you put to a patient all the different options and scenarios and what could happen and what might happen and so on, and they can't weigh up that information to come to a decision. Or they can't communicate their decision either by talking, sign language, or any other means. And they may have incapacity in all of those things, or only some of them. So they may not be able to understand the information relevant to the decision or remember it. But at the time that you give it to them, they may be able to weigh up the information relevant to the decision and communicate it. So it's a very complicated and difficult thing to assess. So let's try and put it in context with a case study. So let's say you've got a patient with early Alzheimer's. They are still reasonably competent. They are in the process of giving, this is a male patient, he's in the process of giving his medically qualified daughter enduring power of attorney. It's not completed though. He's got a full upper denture he won't wear, and his lower teeth are falling out. His family is adamant he wants and needs implant-supported bridges. So this is an older patient who really is in a bit of a dental mess. The patient is only moderately communicative. The dentist is unsure if he really wants implants or if he's just going along with his family on this, because they make a lot of decisions for him. Whether that's right or wrong is not up for grabs here. The dentist is currently providing simple care and suggested dentures may be a better option. Family says no, he's lost weight and can't eat. Patient is also self-conscious about how he looks, reluctant to interact with others. So this is a deteriorating situation, a very sad situation, and one that I think everyone will come across. The dentist has explained to the family that Alzheimer's is a terminal disease. Family is quite positive about it, says he's been given a reasonable medium-term prognosis. Now, the simple care that you've provided so far has gone well, so more complex treatment should be okay. So I defy anyone to say that it is a clear decision as to what to do that is best for him. So how do we then apply the Mental Capacity Act in this very difficult situation? Because it is helpful. So let's start from, does the patient have the ability to decide? Use that two-stage assessment to start with. Does he have an impairment? Yes, he does. Is that impairment sufficient that he lacks capacity? Yes or no? So let's now apply these 4 questions. So can this particular patient understand the information required to make a decision? Bear in mind that he's only got early Alzheimer's, so probably he can. Can he retain the information long enough to make the decision? Dentist and the family, dentist knows the patient quite well. Everyone thinks probably yes. Can he weigh up the pros and cons of the treatment and the alternatives? Probably not. And can he communicate his views? Probably not, as he's only moderately communicative. So now we've got four scenarios here, and 50% of them, so can he weigh it up and can he communicate, is a no. So there is reason to believe that he does not have the best capacity to make full capacity to make this decision. So these are the problems. He's reasonably competent, but only moderately communicative. The enduring power of attorney is not complete, so can't rely on that. Treatment plan is long. What if he deteriorates before treatment is complete? If he goes ahead, will he be able to take care of his implants? And if he can't, will he end up in a worse mess than he's in now? Does cost come into it? He has some capacity, so who can make a decision? You've got a lot of conflicts here. And so this is where I mentioned this earlier. This is have all possibilities been tried to help the patient understand, and they've been unsuccessful. And if the answer to that is yes, then they don't have the capacity. And if it's no, then these are some of the potential solutions that you could think about for a patient in the early stages of Alzheimer's. So patients with Alzheimer's and dementia, they vary in their ability and their capacity during different parts of the day. So perhaps choose a different time of the day, depending on what the patient and the family thinks work best. Think about, are there any other ways that you can put over the material so that the patient will understand? So could you use pictures, drawings, models? Make sure that you pace the conversation to give him time to absorb the information and ask questions, and also ask him to repeat his understanding of what has been said. Those are all very useful potential solutions. And if it proves impossible to know if he's understood and therefore you've got valid consent, then you may need to make a best interest decision. And that's where relatives, carers, others who know the patient well now and also knew him before he developed Alzheimer's. GPs, specialists can also be very helpful in this context. Just to be clear though, a best interest decision is not an opinion that uses what a relative, a carer, or anyone thinks they would like in that situation. So the person that you are trying to get to help you, it is really important that they are thinking only of the patient and not what they would do themselves in that situation. Very tricky indeed. And what we're going to finish up with now, because I know that there are quite a lot of questions in the chat, is a little bit about restraint. And if we go right back to the beginning, as I said, one of the mythbuster scenarios was really to do with restraint. Mental Capacity Act refers to the use of restraint. Some CQC inspectors will ask questions about your restraint policy, although this is more usual for hospitals and care homes. It depends really where your CQC inspector has come from. And there are, in fact, some situations in dental practice where appropriate restraint might be the best thing and desirable. Do have a restraint policy and do make sure you can understand the inspector's questions confidently. So let's think about when restraint might be appropriate. So to go back to the local anesthetic situation, the problem was that the nurse forced the patient to have an injection by restraining them strongly. That wouldn't ever be appropriate in a dental practice or indeed anywhere. However, that is different from holding a patient's hand to reassure them when having local anesthetic, and also to avoid them injuring themselves. So the dental nurse who just calmly and gently just holds the patient's hand. If they are nervous, might want to say to them, would you like me to hold your hand? And because what you're trying to do is to avoid them injuring themselves. Or you might have a patient who is fearful of the air rotor, tries to grab the dentist's hand during treatment. In that situation, the patient could injure themselves as well. Clinicians on the call will have experienced all of these. I certainly have myself too. And then perhaps think about other instances. So the answer to a CQC inspector who's asking you about restraint is, well, we never use restraint. That probably isn't appropriate. And there are some situations where gentle and appropriate restraint are required. So the conditions for using restraint are, 2 conditions must be met. So you must reasonably believe it is necessary to avoid harm, and you must ensure that restraint is reasonable and proportional to the potential harm, which in the safeguarding scenario earlier, where the dental nurse forced the patient, that is not reasonable or proportionate. So in terms of the Mental Capacity Act, make sure that you do have an access to the copy of the Act, the 2005 Act. You can download that from the internet. Just make sure that you have a copy of that on your practice system. Make sure you have a Mental Capacity Act policy, a consent policy, and a restraint policy. Make sure you also provide team training, and in particular, ensure everybody understands the 5 key principles and the 2-stage assessment. And then, just like safeguarding, perhaps consider practicing different scenarios. And there are other scenarios as well in which restraint might be appropriate. I recall a time where we had an 8-year-old child with behavioral issues trying to kick our plate glass windows down in the practice, and when approached by the receptionist, the 8-year-old turned on the receptionist. So in that, and attacked her. And in that situation, then reasonable and proportionate restraint are appropriate. And do make sure that you keep excellent clinical records, and that applies to everything, as I'm sure you know. So I'm going to take questions in a minute, and happy to keep going for as long as there are questions there. I know some of you will need to go back into the surgery. I just really wanted to say that we at Dentistry Compliance are ready, willing, and able to help you with anything we can. So whether you've got a question about safeguarding, about Mental Capacity Act, about compliance, anything at all that you need help with, then Dentistry Compliance, previously Appeline, the company I founded back in 2010, we are very, very happy to hear from you, happy to hear from people who use our system, happy to hear from people who don't. And if you would like to get in touch, there is a phone number on there, or you can scan the QR code, and we will be extremely happy to help you. Rose will be sending out your certificates when you've completed your feedback, and you'll also get a copy of the presentation and PDF, so the contact details will be on there. So thank you very much for your kind attention, and I'm now going to hopefully answer the questions that are in the chat, and I have seen lots pop up, so I hope we're going to be able to get through all of them. Right. All right. Okay. How often should question here, how often should face-to-face training be carried out for safeguarding if online training is fine every 3 years? Personally, I don't think online training is fine every 3 years. I think you would be well advised to do online training every 3 years and face-to-face training every 3 years. Now, this is a personal opinion, and the CQC is a bit woolly about what you need to do. But it's one of those things that, as I said right at the beginning, we're not doing this for the regulators. We're doing this so that we know how to react and respond should we be faced with a safeguarding situation. Please confirm, do only safeguarding leads need face-to-face training or the whole team, and how often? CQC is saying face-to-face training must form part of training for everybody, so not just the safeguarding lead. And then similar response to what I've just said there. And actually a lot of these are not questions, right? They are just people joining the call. Right, there's another question here. Do I have any information on where we could possibly source an external training provider to provide safeguarding face-to-face training in practice? Well, I provide it, but I certainly couldn't provide it to everyone on this call. But if you would like face-to-face training, then I'm very happy to chat to you. There are a number of trainers that do provide this. That I think probably just what I would suggest you do is ask other practices in your area, or Google in your area face-to-face training in safeguarding. Do make sure that it's somebody who understands dental safeguarding, though, because whilst safeguarding is safeguarding, there are a lot of things that are relevant in dental practices that aren't relevant elsewhere. Another question here: if a child is not brought twice to appointments, do we need to refer to social services? I think that is something that you have to use your judgment on, and it's not as simple as they haven't come for two appointments. You know, what if they were ill that day? What if they ran the family cat over on the way to the practice? What are the reasons they were not brought for their appointment? You will know who to be suspicious of. And then you go on to say, every time we've done this, they have said this is not appropriate to be referred unless there is actual evidence of abuse. That is not true. And you need to pursue that rigorously and vigorously. So whoever it is that is they, social services, I presume that is not true. I think, though, that what you should do is provide them with robust evidence that you have significant concern. So I would say, if a child's not brought twice to appointments, there's possibly, hopefully, a reason why they weren't brought, or they simply forgot it. So I wouldn't refer after 2 appointments, but I would find out what the reasons were. And if the reasons don't add up, then you have reason to be suspicious. Something that's also very helpful is adding in other evidence. So child not brought twice to appointments, back it up with other evidence, you know, so that the last time you saw the child, this number of teeth were decayed, and now a much bigger number are decayed. So I think it's clinical judgment that is essential here. I hope that answers your question. Do let me know if it doesn't. I think I might have reached the end of the questions. I think I have, which is very timely. Are there any other questions anybody would like to ask? I can see somebody with their hand up.
Yeah, it's me, Pat. Yeah, I'm
Chair. Hi, Don.
Hi there, Pat. Yeah, I just wanted to follow on to the couple of things that you were talking about there. In Greater Manchester, we've tried to develop a sort of pathway for people to have dialogue with social workers if we are concerned about neglect and safeguarding issues. So the problem we've had historically is that's often personality based, and it sounds to me as if the person this particular dentist or dental nurse has spoken to has maybe not understood the whole situation, because the whole idea of social workers is to try and gather as much evidence as we can. And whilst that's not neglect or abuse, the fact they've not brought the child twice, it forms part of the evidence. So I think that's perhaps something we can take offline again, and maybe try and get some communications out to practices to develop.
Good idea. Yes, you're completely right. So you know, just not bringing a child twice, that could easily be very good reasons for it. But I think add corroborating evidence into that says, you know, I have a real concern about this patient, because this is how things slip through the net. Yeah. So yeah, completely agree. Thank you, Don. And then
the other thing,
else...
sorry, I was going to say, Pat, sorry, the other thing I was going to say following on from that is I think what I'll do is take away as an action point for DPB, if there is an interest in us maybe trying to find some face-to-face training for practices in Greater Manchester, maybe that's something we can do DPB-wise. So I don't know if Lorna and Anne are actually listening to this in a minute, but we'll maybe take that as an action point if we can. And finally, I just want to thank you again for a brilliant presentation. Excellent. I thought the content was spot on. I just think it was really, really good. And I hope everybody else agrees with that.
Thank you, Don. I really, really appreciate that. As you can tell, it's a passion for me, all of this stuff. So thank you very much. I have a hand up from a patient on here. Would you like to ask your question either verbally or on the chat?
Oh, hello, hi there. My name's Manesha. I'm an orthodontist.
Okay.
I've been seeing a lot in our CQC inspection recently about autism training and Oliver McGovern training. Now, that doesn't, forgive me if I missed, if you covered that, but that again needs to be a sort of face-to-face training, and it has been suggested. Am I correct that that could even again be done yearly?
Yes, you are. In fact, it's pretty rigid what the requirements are for Oliver McGowan training, and we're just about to at Dentistry Compliance, Dentistry CPD, about to develop some online training. So I'm not sure actually whether it is mandatory that is face-to-face. I certainly think it would benefit from being face-to-face, but I don't think it is mandatory that it's face-to-face. It is very clear, though, that it is a requirement that that it is somebody with experience that provides the training.
That definitely could be something that could be added then to the training that DPB are offering, I think. Because certainly we do it within the practice, but actually to have the, I think one of the criteria was someone with autism would actually speak to the audience about their experience of living with autism and the barriers that they face. And we're seeing a huge uptick in patients with autism, and they're very happy to share. But everyone is so unique.
Yeah, everyone is very much so. Yeah, very much so.
So I think that that kind of training would really, really help. So
brilliant. Thank you very much for that. Lorna, did you want to come in there?
Yeah, if you don't mind, Pat. Just to say that we've been aware that the Oliver McGowan, I think it's either the tier 2 or the level 2 training, the face-to-face training that you were just talking about is not currently available easily at the moment. So the Greater Manchester Training Hub has got some lead trainers ready. What they are trying to do is source a cohort of patients, trainers with lived experience, so patients that have either got a learning disability and or autism, so that we can begin to deliver this at scale in GM. At the moment, that's the element that they're struggling with. So it is on the radar. We are trying to work with the Training Hub to roll this out. What we're trying to do is find a cost-effective way of being able to build our own training work for faculty, really, so that we can deliver this at scale. Obviously, there's a limited number of attendees per session, and at the minute we just are struggling to get the trainers that we need. But it is on the radar. We are aware of it. If you have a CQC inspection, by all means, you can say that the Dental Provider Board is working with the Greater Manchester Training Hub. We are trying to source training to be able to provide this level 2, tier 2 training. In the meantime, we are working with colleagues through Dental Provider Board to be able to do some sort of just raising awareness and of the needs of patients with learning disabilities and autism, and we're hoping to get that rolled out as a webinar for people very soon, which would be maybe an add-on and an addition to the level 1 that you can do as e-learning at the moment. So there will be things coming out. We'll keep everybody posted, but we are aware that it's a need in our area.
Thank you, Lorna. Really helpful. Barry, did you want to add something?
Yeah, only I spoke to Rob Middlefell about this from the CQC.
Yep.
to do with the full day's training, and they're thinking it's a little bit much for a whole practice team to attend such training at the moment. And although it's, sort of it's come into being, I think there's certainly, as long as people have done the first lot of Oliver McGowan training, and I think the BDA website also has some very good training on that, as well as I think through NHS England. That should be fine, but it's a wait and see, because I think it was brought in without thought of how you get a whole practice team to attend a full day.
Yeah, absolutely. Thank you, Barry. Very helpful. And then we have a question here that is, if we have patients with early dementia or other capacity issues, what type of paperwork do we need in their notes for consent? Consent is always a really difficult, thank you for asking that question. Consent is a massively challenging subject, and for anybody with or without dementia. And I think there is an over-reliance on paperwork and perhaps an under-reliance on making sure the patient has understood. Now, if you relate that to early dementia or other capacity issues, that makes it even more difficult, because actually some of the time you can perhaps only say, well, on this day, this patient could understand it and could remember it, but they might not be able to in the future. So any amount of paperwork is probably not going to help you with that. So the important thing is to have in your records, your patient records, the ways that you've gone about explaining things to the patients, the other alternative methods. So I talked about study models and pictures and so on. Have you done everything you possibly can to make sure that the patient has understood? So I think a lot of people get very hung up on what they call informed consent. Informed consent as such doesn't exist. The consent that matters is valid consent. So valid consent is when the patient has understood all the information you've given them. Or if all you've done is impart information to them and they haven't understood, then your consent is not valid. And actually that could be something that, if you'd like, perhaps you could put it on your feedback forms, or even here, if you'd like, I can do consent as a future subject. It's something I'm very, very passionate about, because I've spent years helping dentists who have thought they had consent and then found when they're in front of the GDC that they haven't. So but I think in answer to the question, what paperwork do we need? You need excellent clinical records that look, that record in the records what you've done, what the patient has said, what you've said, what the options are, the alternatives, if you have contacted other people. And it's not really a case of, getting people to sign things to say they've understood, because actually that would never stand up as consent, because all they have to say is, yes, I know I signed that, but I didn't understand what I was signing. So you need to rely on lots of different aspects of consent. So let's have a look. Face-to-face recommendations are great. Thank you very much for your kind comments there. And then somebody's put on here, Greater Manchester is really forward thinking with training needs. I couldn't agree more. Hats off to you guys. What a great job you're doing. And then lots of thank yous here. Thank you very much. Good. I think that's all the questions answered, and 3 minutes past 2. So I think probably everyone is now going back to work. Hope you managed to get some lunch while we were doing that. Absolute pleasure. If you would like consent and patient records as the next, I'm going to do infection control next. But after that, if you'd like consent and patient records, I'm very happy to do that.
That's great. Thanks, Pat. We will go back and have a chat about that, and we'll get back to you, obviously, and look forward to the next webinar.
Brilliant. So thank you, Don.
Thanks
thank you, Don, and thank you, audience. Thank you
very much. Bye for now.
Bye-bye.